Mm-hmm.
This recording's going.
There's a pop-up on the screen.
It's okay, sweetie. Hi, and welcome to your course on medical errors, brought to you by allceus.com. In this course, we're going to be talking about medical error prevention, specifically as it relates to counselors and psychologists. We need to be aware of the array of problems that are considered medical errors, and the types of medical errors, which can include failure to provide care, which leads to self-imposed harm, basically abandoning your clients or not doing what you need to do to prevent harm, and medical errors leading to harm which is not self-imposed. For example, knowing that your clients are taking 2 different medications that don't work well together, or knowing that your clients are taking a medication and drinking, which, I mean, you could argue that's self-imposed, but most of the time your clients don't intend to harm themselves, they just want to drink and take their lithium. So we need to look at the different types of medical errors that can occur and ways we can prevent them in order to make sure that our clients are as safe as they possibly can be. And we also want to look at methods of intervention, because sometimes things are going to happen and you're going to go, okay, this is really not good. So what do we need to do? We need to have something in place for wraparound services. We need to know that we have a crisis stabilization unit, a detox facility. We need to know that we have somebody who can transport a client from our office to a stabilization unit, like law enforcement or whoever is designated to do that in your town. It's important that you know this ahead of time, because you can't just say, oh, somebody's in crisis, somebody's suicidal, so let me figure out who's supposed to do what. You need to know it, you need to rehearse it, and you need to have a backup plan. If law enforcement is supposed to respond to take the person to the crisis stabilization unit, you can't guarantee they're going to be there in 5 minutes. So what are you going to do if the person is actively psychotic, actively hallucinating, and you have to try to prevent that person from hurting themselves? It's easier in a community mental health facility than it is in a standalone practice. But there are ways to handle it. You need to have backup plans. So be aware. One type of medical error is wrong diagnosis. Now, we talk about this a lot with physicians, but what is it when we talk about wrong diagnosis with counselors? Too often, I see ADD, ADHD, bipolar, and anxiety disorders sort of interchangeably diagnosed. It's like, the person's agitated, we'll just throw a diagnosis on them. That's the worst thing you can do. There are different medications, different courses of treatment, different syndromes that go along with each one of these diagnoses. It's also important to rule out things that are just normal developmental behaviors. If you read the DSM-4, most people, and think back to your childhood, most of us probably met the criteria for oppositional defiant disorder at some point in our lives. Sometimes I do it on a daily basis, but it's important to remember that just because a child is hyper, just because a child has a lot of energy, doesn't mean he has ADD. It means he may be expressing anxiety, he may be just have a lot of energy. So we need to differentiate normal from abnormal, and that's where we need to look at making sure that the behaviors are causing problems in multiple areas of life, not just it's inconvenient for the parents or it's inconvenient for the teachers. We need to look and say, what's motivating this behavior? What are the possible reasons for it? And what possible interventions are there? We also want to look at medically complex cases. When a case is medically complex, it means that there are probably some medical things, go figure, that are or could be impacting the diagnosis. Persons with hepatitis, chronic pain, HIV, fibromyalgia, there are a range of different chronic diseases and problems that impact not only people's physical body, but their mood. When you hurt all the time, it's hard to be cheerful. When your T cell count drops and you're getting sick all the time, it's hard to be cheerful. We need to look at the medications people are taking for these different disorders. If they're taking a opiate-based pain medication, we know that opiates are depressants. We know that's going to impact their mood. So we need to work with the physician if there are no other alternatives and this person has to be on an opiate-based medication. We need to work with the physician and the client to see what we can do to make sure their mood is stabilized. Now, they may not feel hippy-skippy all the time, but we don't want them to be clinically depressed either, or even dysthymic. Who wants to be dysthymic? Pregnant women, prevention. We want to make sure that we educate women who come into our services about the risks and benefits of medication and the risks of different drugs, the risks of alcohol if they're drinking, the risks of marijuana, the risks of tobacco on the fetus and on their own lives. How risky is it for them to be doing this stuff when they're pregnant? Could it cause preterm labor? Could it produce a child who's addicted to a certain kind of medication? Could it cause neurological damage? We know that alcohol is probably one of the worst drugs that women can take, ingest, when they're pregnant. Now people say, well, alcohol's legal. Well, yeah, alcohol's legal. But that doesn't change the fact that there are certain syndromes, fetal alcohol spectrum disorders, that are caused by drinking alcohol when you're pregnant. And these aren't little things, and FASD is not something somebody can grow out of. A lot of times it causes major neurological damage and symptoms that the child will have for the rest of their life. And domestic violence. How many times has a client come into your office in the first session or two and go, my husband beats me? Probably not too often. We need to be on the lookout for signs of domestic violence in order to prevent failure to act. How's that for using some double negatives? Look for injuries that are in various stages of healing. Look for a significant other who doesn't want to let the spouse into treatment alone. They always want to be there. They're kind of helicoptering. Look for different signs that the person may be under duress. Ask them about it. A lot of times, as soon as you open that door, they'll walk through it. Broach the subject. Make sure your clients know it's okay to talk about this stuff. And this would be what would happen. So, back to differential diagnosis. Anxiety. We'll talk about generalized anxiety because that's probably one of the most common that we see just kind of thrown out as a garbage term. This person has generalized anxiety disorder. What does that look like for that person? Do they have insomnia? We know they have to be worried about multiple things most of the time, so that kind of goes without saying. Let's look at those worries. Does the person have something to worry about? Are they unemployed, facing foreclosure, their spouse just left them, and they were just diagnosed with a terminal illness? Well, if they've got all that going on, then they have every right to be anxious, and I wouldn't really call it a disorder. I'd call it a natural reaction. It doesn't mean they don't need help coping with it, but most likely this is something that is situationally bound. So we need to help them learn how to deal with the situation. Depression looks different for different people. For some people, they hurt, they don't have energy, they can't get out of bed. For others, they're grumpy and they're just irritable and cranky and they can't concentrate. Now, sometimes when people are irritable and cranky and can't concentrate, they get diagnosed with anxiety instead of depression. It could be one or the other. This is why you have to do a very thorough assessment with your clients. Ask them about things. And remember that assessment is ongoing. The chances that you're going to make 100% accurate diagnosis after knowing a person for an hour, not real good. Use tentative diagnoses. Use rule-outs. Use information you gather generally over the first 3 sessions before you settle on diagnosis. Now, if somebody comes into your office and their level of functioning is just not good, and you think they might benefit from an assessment by a psychiatrist for medication, and they're willing to consider taking medication, by all means make that referral with either a rule-out diagnosis of anxiety. That way the psychiatrist knows kind of what you're looking at. Make sure you obviously get a release of information before you share that information. But just because you've only met the person for 1 hour, if you know that their functioning is so bad that they're in a desperate state, they're in crisis, we don't want to say, well, you know, after we've seen each other 3 times, which is generally 3 weeks, then we'll talk about maybe what your diagnosis might be. They're never going to come back. They need to feel better now. Have some tools in your proverbial toolbox to make sure that you can give them. Cognitive behavioral stuff is wonderful. Journaling is wonderful. Support groups, if they're willing to go, are wonderful. We know that people's stress levels are lowered if they believe they have a good support system. It doesn't matter how big it is. If they believe they have a good support system, then they have lower stress levels because they have people who can buffer them from stress. We need to make sure to rule out delirium. I work in a facility with people with co-occurring disorders. We see a lot of substance-induced fill in the blank. You need to rule out standard delirium. You need to rule out substance-induced delirium. You need to rule out anxiety or depression caused by substance intoxication or withdrawal. You don't want to start medicating somebody for depression if they're coming off a 3-day binge, necessarily. Now, again, remember, if their functioning is so low that they're in crisis, they probably need to be in a detox facility. We need to make sure that we help people safely detox. Again, educate people. Back to alcohol. Alcohol is one of the most dangerous drugs to detox from. Why? Because some people, as they detox, they will experience a hypertensive crisis. Alcohol is way more dangerous to detox from than opiates. Opiates, you feel like you want to die, but chances are you're probably not going to. We need to pay attention to people who are hypertensive, if they've got high blood pressure or heart disease in their history. We know that high levels of anxiety tend to increase blood pressure. So if you've got somebody who has hypertension, remember we were talking about medically complex, if they've got hypertension and they're also anxious, we want to be really careful and monitor this person closely to make sure they're not putting themselves into a situation where they could have a stroke. Look for signs of intoxication. Know what intoxication looks like for the big ones: marijuana, alcohol, opiates, spice, K2 is big now. Know what that looks like because it can look pretty darn scary, but it can also look very benign depending. Little tangent here. Spice is not regulated. So every bag of spice that people get has a different quantity or a different density of the psychoactive chemicals. I've seen consumers use it and get nothing more than what would be expected, if you will, from a normal marijuana high. I've also had to call in the paramedics to come take people to the hospital because their heart was over 200 beats a minute and they felt like they couldn't raise their arms. They were like so heavy they couldn't move or get out of bed. There are stories, there are anecdotes of people having psychotic episodes after using spice. And there are reports of the effects of spice lasting, instead of a few hours to a day, a week, sometimes 2 weeks. So be aware of what the symptoms look like. Ask your clients about herbals that they're taking. oral herbs as well as anything they've smoked, injected, inhaled, any way you can get it. Ask them about it. That will give you information about whether what they're going through is intoxication or withdrawal, biochemical, or situationally bound. Multiple sclerosis. Want to look out for that. That can also appear in people, or not really appear, but people tend to be diagnosed later in life as opposed to in their childhood with multiple sclerosis. So be aware of signs and symptoms of multiple sclerosis, especially difficulty with coordination. This will probably rarely occur in your practice, but I don't get out much, and I know 2 people who were diagnosed with MS while they were in college. So it isn't all that rare, but it's rare at the same time. That didn't make any sense. You get my point. Medication interactions. You need to be aware of what different medications do. We all know of people who take medication to go to sleep and then medication to wake up. You want to be aware of what over-the-counter medications do with prescription medications. You want to be aware of what medication interactions will do with alcohol and marijuana. Those are the 2 big ones that you want to be aware of. Cocaine, yeah, that one too, since it's a stimulant. You don't want somebody taking Adderall and cocaine. You really don't want them taking cocaine at all. But be aware that some medications may add up. Instead of taking 1 and 1 and getting 2, you take 1 and 1 and you get 6. So somebody could accidentally take too many depressant medications and put themselves in a really bad physical state. Pain management is crucial for a lot of medically complex cases. What do I mean? Well, if you can't take opiates, how do you manage pain? There's a lot of ways. Yoga, water therapy, hot and cold presses, stretching, TENS, trans-electronic something stimulation, nerve stimulation. These are little patches that people can put on, and it's a little tiny electric charge, feels almost like somebody doing their fingernails on you. Doesn't hurt, but it bombards the nerve endings so they don't feel pain. They're not transmitting that pain signal. There are a lot of other things people can do for pain management. Hydration can help a lot. They need to work with their physician, though. It's crucial that they work with their physician to identify anything that they can do. Acupressure, acupuncture, massage, tons of stuff. Now, does it make it really go away like that and put you in happy land? No. However, it may improve the person's functioning significantly in many other areas of their life if they're not always completely vegged out on Vicodin. Hepatitis, a disease we generally see, you can have hepatitis B, which is a blood-borne pathogen, and you can have hepatitis C, which is often caused by alcohol abuse. Hepatitis, hepa meaning liver, and itis meaning inflammation. Inflammation in the liver, it can be painful. There are a lot of other side effects, bloating, swelling, jaundice, that you need to be aware of. Make sure somebody that has a chronic medical condition, no matter what it is, make sure they're taking good care of themselves, because the body is better able to repair itself and help the person function if it's getting the basic building blocks of sleep and nutrition and hydration. And be aware in the elderly. Elderly people do not process all medications as well or the same as people who are below 65. This is crucial because certain medications, especially your stronger benzodiazepines, can build up in the liver of people who are elderly and eventually build up to a level of toxicity. Elderly patients should be seeing someone who specializes in geriatric medicine, geriatric psychiatry. It's a whole different ballgame. Their biochemistry has changed. It happens. We don't want to admit it, but it happens. It's important to be aware of that so your patient doesn't accidentally overdose by taking the prescribed amount. Elders often have a lot of pain. Make sure they're aware of pain management strategies. And people who are older, by virtue of nature, often experience a lot of losses because of their age. Every time they turn on the TV, somebody that they grew up watching on TV news or some star that they grew up watching. I remember a couple weeks ago, I was watching TV and whoever the guy is that played J.R. Ewing died. I was like, oh, J.R. died finally. There was all the hubbub when I was little because he was on like the first soap opera. And, you know, I felt kind of old for a few minutes because J.R. died. There are, you know, Gerald Ford. You know, we've got to look at who's getting older and what they mean to people. We need to take that into consideration because it can eventually, if there are several deaths end to end to end, and we've got a client who grew up in that era, it may impact them and trigger a grief, depressive reaction. Just be aware. Elderly people, as I talked about earlier, can have hepatic toxicity. Say that 3 times. Basically, that means that stuff builds up in their liver and faster than in people who are not elderly to a toxic level. Chronic pain. That's one we've already talked about. Medication interactions. Most of you know people who are elderly who are on like 17 different medications. Blood pressure medication, sugar medication, pain medication, glaucoma medication, you name it, there's a medication for it. We need to be aware of what medications they're on and what side effects they may have. Grief, like we just talked about. As people get older, there are certain just natural milestones, if you will, that impact people at various times. Be aware of those milestones. For some people, their 60th birthday. For some people, their 40th birthday. For some people, it's not until they hit 80. You need to talk with your clients and assess with them how they feel about things. If they hit 40, 60, 80, 90, and they don't care, well, then it's not a clinical issue. That's wonderful. But be aware. Be aware in elderly people of early signs of dementia, confusion, loss of cognitive ability, loss of the ability to express themselves, repeating themselves. Maybe they say something, and then 5 minutes later they tell you the same thing. And then 5 minutes later they tell you the same thing. Now, I do that periodically, but it's generally because I'm going a mile a minute. It's when it becomes chronic. If you notice this happening a lot, not just one day somebody's having an off day, you may want to have them assessed by their physician for dementia. Pregnant women, as I talked about earlier, there are benefits and drawbacks to medication. I worked on a unit with pregnant and postpartum women for several years. And let me tell you, having 10 detoxing, unmedicated pregnant women in one small space for 6 months at a time can be a challenge. However, a lot of the medications, the psychotropic medications, especially your mood stabilizers and your antipsychotics that are out there, are not safe to be taken during pregnancy. especially not during the first trimester, but most doctors err on the side of not during pregnancy at all if you can maintain the mother's safety. And that was the key. In the residential facility, we were able to maintain their safety. We were able to monitor their mood swings and adjust treatment accordingly and make sure that they and the baby were safe. This is always a judgment between the mother and the physician about which drugs can and cannot be taken. There are many SSRIs that are considered relatively safe to be taken during the second and third trimester of pregnancy. However, if you watch any TV at all, I'm sure you've seen the ads for if you took Zoloft when you were pregnant and your baby has any of these problems, the medication could be to blame. There's a lot of things that could be to blame. So you need to weigh the pros and cons, and sometimes it's really hard to be therapeutically neutral when you're talking to a parent, when you're talking to a mother about this. But she needs to dig deep down inside and decide, is my quality of life worth risking the 20 or 30% chance or whatever it is that X will happen? Sometimes, especially for parents that are mothers who are an outpatient, there may be a choice there because they become suicidal if they're not medicated. They may not be able, for one reason or another, to go into residential. Lots of factors that need to be considered, but you need to document, and did I say document, that you talked about any of these issues with your client and that you made a referral for your client to go see a physician so she could talk about these issues with the physician. Talk with your pregnant women about illicit drugs. Many of these drugs go straight to the fetus, so it's important that the mother know that, a dose for you at 100 pounds is pretty darn high for a fetus of 1 pound. Aside from the fact that it's just really bad for a immature neurological system to be exposed to these kinds of things. And we talked about alcohol earlier. Alcohol is probably one of the most dangerous drugs that a mother can take during pregnancy. So, when people are pregnant, what can you do? Just like people who have pain who don't want to or can't take opiate pain medication, you need to look at alternatives. You need to work with the physician or the midwife. If a client is clinically depressed or has clinical levels of anxiety or is diagnosed with bipolar, decide first whether she can be safe in outpatient, and obviously decide this with the patient and her significant others. There are many patients who have supportive families that can help them through this. Look at alternative treatments, such as acupuncture, acupressure, light therapy, if you happen to be in a place where it's really dark and maybe there's some seasonal affective stuff going on. Talk about cognitive behavioral interventions and support groups. There are a lot of options besides medicating somebody when they're pregnant. And domestic violence. Make sure you educate clients about the cycle of violence if you even suspect that there might be something going on. Help them understand that the honeymoon phase, oh, he's so sorry, yeah, that's not uncommon. Help them understand that it usually doesn't stop there. Help them look at patterns with this particular person to see if this is a repeating pattern. Help them gather the objective evidence and make the decision for themselves. Educate them, provide them information on resources that are available. You can lead a horse to water, so to speak. Make sure they know where they can go. Effects on mental health and substance abuse. Domestic violence kills self-esteem. People feel like they're not worth anything, that they're going to be alone forever, that everything that ever happens that's bad is their fault. Well, if you feel like that, you're going to be depressed too, probably, yeah. And the anxiety and the post-traumatic stress disorder from never knowing when the spouse is going to be set off, that's exhausting. It can cause or greatly contribute, depending on your theoretical ilk, relapse of mental health and substance abuse issues. If things get bad enough, at a certain point, a person's got to make the pain stop. Make sure you have a safety plan with all your clients. What's going to happen if you start feeling depressed again? What are you going to do if you feel like you want to use? What are you going to do if you actually relapse? What are you going to do if your spouse becomes violent? Now, obviously, the last one you only bring up if there's domestic violence issues. But they need to have safety plans for themselves. They're in no position to think about, oh, well, I've got these different options. I'm not feeling so good today, or I'm starting to feel suicidal, or like I want to cut. By the time they get to that point, they're not considering the options of, well, what else could I do? They need to know the options and have them written down somewhere that they can easily access. Make referrals to domestic violence shelters. Make sure clients know where legal assistance is. Make sure they know about support groups and housing. And if they need employment or want employment, help them figure out where to get that. Now, caveat, I would think you would know this, but I will say it. Don't give them this stuff in writing. If they are in a domestically violent relationship and their abuser finds out about it, they find all this stuff about domestic violence shelters and where they can go, guess what's going to happen? It's going to be a bad scene. Be very, very careful and encourage the client to be careful. If they go onto a computer to look for information, they shouldn't use their home computer. They should go to the library and use a computer. Do something where the abuser can't easily find out what they've been looking at on the internet. In summary, accurate assessment occurs over time. There is no substitute for time. You're going to get in that first meeting what the client wants you to have. And that's all. You may suspect a few other things, but the first assessment is for you to get to know, first meeting is for you to get to know each other. Over the next 1 or 2 meetings after that, you'll get a better clinical picture, a more rounded picture of what this person's life looks like on a day-to-day basis, what symptoms are bothering them, and what mitigates or exacerbates those symptoms. Expect diagnoses to change over time in response to life. Sometimes life is going to hand people lemons, and they have 2 or 3 or 4 or whatever bad things happen in a row, and they get depressed. And you hear their story and you go, you know, I don't blame you. Let's see what we can do to help you through this. Just because it's situationally caused, and they have every right to feel depressed, doesn't mean that we say, there's nothing I can do. That's the time that we're most helpful, because we can say, let's try these different tools. Differential diagnosis is crucial. Crucial, crucial, crucial to helping your client. If they start on medication, talk with them about how they're feeling on it. More than once, I've had a patient tell me, well, the doctor prescribed this medication for me for depression. And my eyebrow kind of goes up, and I say, really? How are you feeling now that you're taking that? Because deep down inside, I have a pretty good suspicion that the patient was never depressed. And in this particular case that I'm thinking of, the person said, I feel like I'm going to crawl out of my skin every time I take the medication. And I said, really? What did your doctor say about that? Dead silence. Did you tell your doctor? No. This is what he told me to take. We need to encourage our clients to advocate for themselves. Even if she was depressed, the first medication that she was put on may not be the right medication for her. We know that there's a whole class of SSRIs out there, and not every SSRI works for the same person. And the explanation for that is for your psychopharmacology class. But it's important to remember, to help clients remember to advocate for themselves. They know themselves better than you do and better than their doctor does. Ethical care requires awareness and intervention. We need to try to prevent whenever we can, and if we see that there's a problem brewing, we need to step in. I hope you've enjoyed this presentation, and I will see you at your next renewal. Bye.